To Plexus Ortho, and today we're going to talk about osteomyelitis in children, a very important topic for your practical exams. This case is often kept, you have a chronic osteomyelitis case which is often kept in your exam, so you must know a little bit about its theory and also that you can also attempt this question in your exam as well, theory exam as well. So osteomyelitis is very common in the pediatric age group. In fact, you can see it in about 1 in 5,000 children. You can see it in 1 in 5,000 children in childhood, and it is basically a result of hematogenous seeding of bacteria to the metaphyseal region of the bone. So that is the most common reason why osteomyelitis occurs in children. So with that introduction, let's go to the epidemiology. As I've already said, it is seen in 1 in 5,000 children. It's a very common condition, more common than we think it is. And it is 2.5 times, 2.5:1 is the ratio between males to females. So it is more common in boys as compared to girls, and it is about 2.5:1 in ratio, right? And usually the type of seeding or the method of spreading of infection is hematogenous. Most of the infections occur through the hematogenous route, right? And what are the other risk factors associated with it? Any trauma to the metaphyseal region or to the bone can cause this kind of predisposition to osteomyelitis. Hemoglobinopathy, any hemoglobinopathy or problems with bleeding disorder or any other issues in the blood can cause osteomyelitis or can be predisposing to osteomyelitis. Juvenile rheumatoid arthritis is a predisposing factor or a risk factor. CKD, chronic kidney disease or chronic renal disease, can cause as a predisposing factor. Immunocompromised patients like HIV or other immunological disorders is also a risk factor, and varicella infection. So these are some of the common risk factors. And one thing I've missed is probably the diabetes mellitus. Type 1 diabetes mellitus is very common in children. So these are some of the common risk factors for osteomyelitis in children. So coming to the pathophysiology, right, usually it is the local trauma. So most patients or most children will give some history of local trauma, following which they develop osteomyelitis. So why does osteomyelitis occur very commonly in children, and why does it occur more so in the metaphyseal region? Now, the reason why it occurs in the metaphyseal region is because of the following reasons. It's very important to understand these reasons. Why does it occur in the metaphyseal region? What are the factors or the pathophysiology that causes osteomyelitis? So here in the metaphyseal region, the blood vessels form a loop. They form a loop-like structure in the metaphysis where the blood flow becomes sluggish. The blood flow becomes sluggish. So this is one of the most important characters where the metaphysis forms a loop, or there's a sharp turn of the metaphyseal capillaries and which convert into venous sinusoid here. When they do so, they get stagnation of blood happens and blood flow becomes sluggish, because of which it gives bacteria time to lodge in this area and cause infection. There is decreased pH and decreased or low oxygen tension in this area. There is decreased pH and low oxygen tension in this area, which helps in bacterial growth. Is decreased or sluggish blood flow in the metaphyseal capillary. Second one is low pH and low oxygen tension. And third one is infection occurs after here the local bone defenses. That means the macrophages and other cells which are required to defend against the bacteria are lacking, and therefore this also predisposes to infection. In the bone, the infection usually spreads through the Haversian and Workman's canal, which is easier in the metaphyseal region, right? So these are the predisposing factors of reason why infection occurs in the metaphyseal region and why pediatric bone is more prone to osteomyelitis and why it occurs through the hematogenous route as compared to adult bone and adult osteomyelitis. Now the most common areas where osteomyelitis occurs is in the proximal tibia. Is very common. Distal femur is very common. So distal femur and proximal tibia are almost equal in number, right? So these are the two most common areas where the infection can occur. And we've also learned in the septic arthritis chapter that in some joints the metaphysis is intra-articular. So in these cases, osteomyelitis can be converted into septic arthritis because the capsule is covers the metaphysis. So metaphysis is intra-articular, very important concept to understand. And which are the joints where the metaphysis is intra-articular? The metaphysis is intra-articular in the hip joint. It is intra-articular in the shoulder joint. It is intra-articular in the elbow joint, and it is intra-articular in the ankle joint. One strong exception to this is the knee joint. So knee metaphyseal osteomyelitis should not get converted to septic arthritis via the contiguous fashion. That means it will not become septic arthritis. It is very unusual for it to become the septic arthritis. So what are the joints where the metaphysis is intra-articular? One is the elbow, two shoulder, three is the hip joint, and 4 is the ankle joint. The knee is not, the metaphysis is not intra-articular in the knee, and therefore the osteomyelitis does not get converted to septic arthritis. So coming to the etiology, the one thing you must understand in the etiology, this question is often asked in MCQs and everything. Staph aureus is by far the most common organism, doesn't matter which age it happens. So if you see it, it happens most commonly in 0 to 3 age group. It happens most commonly in the 3 months to 4 year age group. It is most common in the more than 5 age group. So Staph aureus is the most common organism that causes osteomyelitis, right? So you have the MRSA version of the Staph aureus as well, because based on this you have to change your antibiotic, and something called as PVL positive strains are also seen. So what is PVL positive strain? PVL is Panton. You would have read this in your microbiology chapters. Panton, Valentine, leucocidin, cytotoxin. So PVL. So some of these are PVL positive strains which are associated with more complex infection with severe fever, abscess, DVT, etc. So MRSA, normal Staphylococcus aureus is associated with simpler infection as compared to MRSA strains and PVL strains. Very important to understand. Group B Streptococcus is also the second most common. Group B Streptococcus is the second most common organism in case of neonates. Kingella kingae is becoming more common as compared to Haemophilus in the toddler age group, because a lot of these Haemophilus, these toddlers have been immunized with Haemophilus influenza infection. As they get older, Mycobacterium tuberculosis is also seen. Another organism which is seen is Pseudomonas. Pseudomonas may be seen in children. Osteomyelitis of the foot with some penetrating injury, Pseudomonas is seen. You can see Salmonella infections. Where do you see Salmonella infections? You can see Salmonella infections in sickle cell disease. Sickle cell disease. So that is about the etiology. One thing, important thing you have to take away from the etiology thing is that Staph aureus is the most common infection that happens in, it doesn't matter what the age group is. Now, so we have described the way in which osteomyelitis occurs, the pathophysiology, the etiology. Now let us come to how does acute osteomyelitis occur. Acute osteomyelitis occurs most commonly because of a direct blow to the metaphyseal region. Direct blow to the metaphyseal region, right? So this is, let us say, is a proximal tibia. You have the growth plate here. This is epiphysis. This is a growth plate. Then you have loops of vessel where the capillaries become venous sinusoids. There's a sharp turn here. The blood flow becomes sluggish here, and therefore there's an increased chance of the bacteria getting lodged there. There is decreased pH, decreased oxygen tension here, because of which the infection happens. There is no decreased body mechanism, local defenses, right? Macrophages and other white blood cells are less in this area, and therefore infection can happen here. So this is the reason why osteomyelitis happen, and we also discussed how the metaphyseal infection can spread into the joint and cause septic arthritis. Now let's come into the chronic osteomyelitis. It's a very common exam case that you might get. We can discuss this in our clinical cases as well. But chronic osteomyelitis, what are some of the features that you have to understand of? You have to know that a bone becomes avascular. A small piece of bone becomes avascular, more so in the children, more so in the pediatric age group, becomes avascular. So bone becomes avascular, and this is called as the sequestrum. a dead piece of necrotic bone which has been walled off from its blood supply is called as a sequestrum. This can be a nidus for further osteomyelitis and persistent infection to happen. An outer layer of new bone is formed around it. An outer layer of new bone is formed. There's a dirty granulation tissue between the sequestrum and an outer layer of new bone which is called as involucrum, and we can see here there is a healthy bone which with marrow here, which is depicted as A, and here you can see the periosteum which is being lifted off with the abscess. So this is an abscess here, and it finds a way to break out. As we know, pus and abscess tries to find a break to break out, forming a sinus tract. So many times we can use a dye to put it into the sinus tract and take an X-ray or CT scan to see where it is leading to and where we have to do our curettage and sequestectomy so that it does not recur again and the infection does not recur again. So these are the general features. To repeat, sequestrum is a dead necrotic piece of bone which has been walled off from its blood supply, and it can become a nidus for chronic osteomyelitis. Involucrum is a layer of new bone growing outside the sequestrum, and it is seen in chronic osteomyelitis. So when you see a sequestrum, it already indicates that the patient is having chronic osteomyelitis. What are the types of sequestrum? This is very commonly asked in your clinical exam, so you must be aware of it. So tubular sequestrum, where a whole tube of sequestrum is seen in the X-ray, happens in bacterial infection in children. It doesn't happen in adults. Feathery sequestrum is seen in pyogenic infection or bacterial infection. Coarse sandy sequestrum is seen in tuberculosis. Dense ivory sequestrum is seen in syphilis. Ring sequestrum can be seen when you have a pin tract infection or when you are not irrigating when you put the Schanz pin for external fixator application. Then thermal necrosis occurs, causing ring type of sequestrum. You can have the stump of an amputation can also have a ring sequestrum, right? So Bombay sequestrum is seen in calcaneal osteomyelitis. Kissing sequestrum is seen in TB spine. And I was already telling you, you can have a ring sequestrum or a conical sequestrum in amputation stump. So these are the different types of sequestrum that are seen, very important for your clinical exams. So how do you classify osteomyelitis? We have already discussed about acute osteomyelitis and chronic osteomyelitis. Acute osteomyelitis and chronic osteomyelitis. In between, we also have another term called as subacute osteomyelitis. Subacute osteomyelitis, acute osteomyelitis, subacute osteomyelitis, and chronic osteomyelitis. There is no strict timeline, right? But a few weeks we would call it acute, few weeks to a few months you can call it subacute, and more than a few months you can call it chronic osteomyelitis. More than a few months you can call it chronic osteomyelitis. How does a child present? Unlike an adult, the symptoms may be more severe. The patient may have high grade fever, may appear toxic, and in very severe cases can be unresponsive. Earlier stages will refuse to bear weight. In whichever limb this happens, it refuses to bear weight. The limb will be edematous, warm. The clinical presentation of the patient. Now coming to the imaging, what will you see? The imaging, you should obtain an AP and lateral view of the affected suspected area, right? In early films or very early stages, in the first few days, you will only see a soft tissue edema. After about 5 to 7 days, you can see a periosteal bone formation. Periosteal bone formation can be seen. In 10 to 14 days, you can see osteolysis. The bone is become more radiolucent. Then metaphyseal rarefaction can be seen, and possible sometimes you can see an abscess as well. So this is probably within 10 to 14 days or beyond 10 to 14 days where you see a abscess or a cavity in the metaphyseal region. So first, initially you will see a soft tissue edema in the X-rays. In 5 to 7 days you will see a periosteal bone elevation. In 10 to 14 days you will see a osteolysis and more radiolucency, and an abscess formation can be seen. Now, in specific conditions, we can use a CT scan, which is used in later cases to identify sequestrum, sinus tracts, where exactly we have to approach and do surgery. So, a CT scan can be helpful in the later stages of the disease. MRI is useful in very early stages where we cannot diagnose. X-ray is not very helpful. Then the MRI will show changes in the abscess. We may show abscess, soft tissue edema, and early marrow changes can be seen. So, therefore, MRI is very helpful in the early or acute stages, and it is 88 to 100% sensitive and specific for if gadolinium is used. It is highly specific and sensitive if gadolinium contrast is used for the MRI scan. Bone scans can also be used, but MRIs have generally replaced bone scans, and bone scan can also diagnose infection, but very rarely used in current scenario. What are the lab investigations that you have to do? WBC, you have to do a total blood count in which the WBC will be increased, and it is increased in only about 25% of patients. So it is not a very reliable indicator. CRP is a very good reliable indicator. It is elevated in 98% of the patients. It is raised within 6 hours after the infection, and it goes down quite rapidly once the infection settles down as well. So it's one of the most sensitive marker to monitor infection, osteomyelitis. So if the C-reactive protein does not reduce after treatment in 48 to 72 hours, then maybe it is a good indication to do surgery, or some change in treatment of surgery has to be done. ESR is also elevated, but is not as specific as CRP. And one new test is available, which is called as procalcitonin test, which is very specific for bacterial osteomyelitis. So what are the tests that are available or we should do for osteomyelitis? WBC count is increased, but is increased only in 25% of the patients. A CRP should be done, which is very sensitive, and it is a good marker for the clearance of infection as well. ESR is done, which is not as specific as CRP for infection. Procalcitonin is very specific for bacterial osteomyelitis, and it is useful for in cases where the other blood tests are plus or minus or difficult to diagnose the condition. And in some cases, we can also send culture sensitivity. If there is a pus breakout, culture sensitivity can be sent, and we can identify the organism, and based on the organism, we can titrate our antibiotic as well. So in early stages, in acute osteomyelitis, in early stages, we can attempt non-operative management. So we can empirically start antibiotics. If you do not suspect MRSA resistant, you can give cefotaxime 100 to 200 milligram per kg of body weight for 24 hours can be given. However, if methicillin resistant Staphylococcus aureus or MRSA is seen, then you have to use vancomycin. In MRSA, in methicillin resistant Staph aureus, you can use vancomycin. Right? If it is a gram-negative organism, you have to use gentamicin or amikacin can be used. And in cases of salmonella, suspected salmonella, oxacillin and ampicillin or chloramphenicol can be used. So based on the organism and suspected age of the patient, you can start. But generally, the most common being the Staph aureus, we can usually start with cefotaxime till we get a culture sensitivity, and based on the culture sensitivity, we can start the appropriate management. We have to do surgical drainage and debridement, and antibiotic therapy has to be given. We have to remove the abscess. For example, we have to drain the abscess, make sure there is no sequestrum or anything deeper, right? Drain the abscess, probably make some holes in the bone and drain this abscess out, and make sure there is no chronic infection, or it should not progress to chronic infection. So basically, in early stages, you do surgical drainage, debridement and antibiotic therapy. Sequestrum is completely off. So we know what sequestrum is. Sequestrum is a dead necrotic piece of tissue which is surrounded by dirty granulation tissue, and which is covered surrounding it by an involucrum. So you should make sure that it is completely off and it is taken off. So this is called as curettage sequestrectomy, removal of the sequestrectomy, and saucerization. saucerization should be done. So once you do this, uh, there is a there is less chance for the infection to recur, because the sequestrum has been removed and we have opened the bone out so that the it is exposed, and any infectious material can be exposed out and can it doesn't settle in the bone and cause persistent infection. So what must be done? Curettage sequestrum and sequestectomy and saucerization has to be done, and of course appropriate antibiotic has to be given post-op. Long-term antibiotic may be from 4 to 6 weeks. It could be IV antibiotic or oral antibiotic, but the appropriately sensitive antibiotic has to be given. So this is in brief about osteomyelitis in children. I hope it helps you to answer some questions in the exam. Thank you very much.